Thank you for joining us this afternoon for today's Habesha Health Talk on managing diabetes. For those who may be joining us for the first time, I want to share that Habesha Health is a virtual platform dedicated to increasing awareness and addressing Habesha health disparities in the diaspora. This platform is designed for our Habesha community members to find and utilize information on Habesha healthcare providers, as well as health education. If you are able to donate to Habesha Health, please do so by visiting habeshahealth.org. Your donation will support Habesha Health's administrative expenses and allow the team to continue providing quality content, as well as getting it translated to different languages in the future. And it is also tax deductible. Before we jump into our talk today, I want to review a few housekeeping things. First, this discussion is being recorded for our website as a resource for our community. Second, please put your Zoom settings on mute if it did not mute automatically. For your viewing pleasure, you may use the speaker view, which can be found on the upper right corner of your screen. If you are not able to make it to our previous discussion on understanding diabetes, please visit our YouTube or our website. We'll put our website and our YouTube page on the chat box. If you have any questions, please type them in the chat box below. Our Habesha Health team members are monitoring the questions, and we will do our best to ensure that it is answered during Q&A. So we are going to start with introductions. I am honored to moderate this event. My name is Samson Mael. I serve as the Chief Operating Officer of Ritter Center, which is a federally qualified community health center in Marin County. At Ritter Center, I manage all phases of clinic administration and provide leadership and direction, including but not limited to strategic planning, organizational and business development, risk management, compliance, revenue cycle, and quality assurance. I also serve as COVID-19 Deputy Commander. Under my leadership, we administered over 40,000 vaccines to patients and Marin County residents through an innovative partnership with Marin County Public Health, which contributed to Marin County having the highest vaccination rate in the state of California, also in the nation. I am committed to creating a safe and welcoming environment for all patients to receive equitable, high-quality healthcare services. My passion for healthcare stems from growing up in Oakland, where I witnessed firsthand the prevalence of inadequate healthcare to disadvantaged communities. I want to do my part to ensure that everyone, regardless of socioeconomic background, receives quality healthcare. I earned a Master of Science degree in Healthcare Administration with a focus on management and change in healthcare from California State University, East Bay, as well as an undergrad degree in sociology with a minor in Youth Services Administration from California State University, East Bay. I am a member of American College of Healthcare Executives.
Thank you, Samson. Welcome, everyone. My name is Jerusalem Makonnen. I'm a family nurse practitioner and have been doing this work for about 25 years now. I currently work in a primary care setting at One Medical, but prior to that, my first 10 years of my career, I worked in community health at La Clinica, as well as San Antonio Neighborhood Health Center, where I had the privilege of working with the Habesha community for 10 years. And it gave me great joy, and it's now full circle to come back and work with Habesha Health here. I was also a professor at University of San Francisco, at UCSF, in the Family Nurse Practitioner Program, teaching nurses for about 7 years. I'm again honored to be here as a part of this crew to talk about diabetes and welcome your questions, and I'm happy to get this going.
Thank you, Samson and Jerusalem. Yes, I'm also honored to be here. Thank you, everyone who is back from the last talk, and welcome to those who are joining us for the first time. My name is Mahedere Solomon. A lot of people know me as just Mimi. I'm a family nurse practitioner as well, and look up to Jerusalem as sort of a mentor for many years back. And you know, Samson, I worked for him at the Ritter Center. Also, I have been a nurse practitioner for the last 18 years. And before that, I was an RN. I have tried a little bit of everything, worked inpatient, outpatient, did a lot of work with Habesha patients at Highland Hospital in the women's clinic, and tried some administration stuff at the Ritter Center where I was a chief medical officer working for Samson, and just really love this platform where we're able to share information here and contribute what I can to our collective health as a community. So thank you, Habesha Health, for having me also.
Thank you for the intros. I see that both of you are nurse practitioners. Can you define what an NP is?
Absolutely. So for those of you who don't know what a nurse practitioner does, we're advanced practice nurses. We've furthered our education to either a master's or doctoral level. And in the US, nurse practitioners, the profession was created to fill the gaps in healthcare where there weren't enough physicians. Today, we have nurse practitioners and physician's assistants who, although our training may be a little bit different, very parallel, and we all work in all sectors of healthcare now. In direct patient care, like in hospitals and clinics, we assess patients, we diagnose diseases, disorders, we treat patients, we do a lot of preventive things and health promotion. And we also, our duties include things like diagnosing diseases, treating patients with medications, ordering labs, x-rays, prescribing ongoing treatments, even outside of meds.
Thank you. So this will be a Q&A style discussion. The goal is not for clinical consult, but rather a conversation in the community. And we hope you feel a part of the discussion. We'll address questions from the audience at the end of this live discussion. So please send us your questions as they come up using the chat box, and you'll be able to unmute yourself to ask questions as well. And we are going to do a quick overview of diabetes from the previous discussion and model 2 common scenarios around diabetes management. Diabetes is a chronic, which means long-lasting health condition that is becoming more common in our Habesha community. In the US, 34.2 million people have diabetes. That is 10.5% of the US population. And 422 million people in the world have diabetes. According to the World Health Organization, the Habesha community represents the 5th largest diabetes patient population in Africa. That is big. In our community, the word for diabetes is shikor. It absolutely makes sense. That's what it is. If you have diabetes, your body either doesn't make enough insulin or can't use the insulin it makes as well as it should. When there isn't enough insulin or cells stop responding to insulin, too much blood sugar stays in your bloodstream. Therefore, there is too much sugar in your body. Mimi, what are the symptoms of diabetes?
Oh, symptoms of diabetes that you might notice are a little bit increased thirst. You always feel like you need to have more water, your mouth is dry, frequent urination, and a lot of times people will say, well, I'm drinking more water, but really paying attention to, are you using the bathroom more often, excessively hungry, and an unexplained weight loss, even though you're always hungry, feeling very fatigued, tired, irritable. And if you get any wounds, they are slow to heal, and getting infections, either the gums, the skin, and for women, vaginal infections, particularly yeast infections. Those are some of the first signs people might notice. If a person's blood sugar is dangerously high, that means that they probably didn't pay attention to some of those other things that I just talked about. But if you start having blurry vision, feeling lightheaded, your skin is always flushed and warm, drowsy, your heart rate seems like it's going a lot faster than what you're used to, feel like you have an acetone or a fruity odor coming from your breath, having lots of abdominal pain, vomiting. If you're having any of those symptoms, you need to seek medical care urgently. I recommend you call your primary care provider or go to emergency room or urgent care. Don't wait.
How is diabetes diagnosed?
Well, so diabetes is diagnosed either in the primary care setting or in a hospital in a laboratory setting with a blood draw. So, and there's a few standard criteria, and you have to meet one of the following criteria. So, if they're drawing a fasting blood sugar, where you haven't eaten anything overnight, the diagnostic number is 126, right? So that if it's 126 or higher and it's fasting, that is a diagnosis of diabetes. If you're not fasting, so if it's a random blood draw, then that number has to be 200 or over in order to have a diagnosis of diabetes. There's another number that we use, it's called the hemoglobin A1C. You might just see it noted as A1C. And that number it gives us an average. So it's not a one-time, like not in one time setting, but it's over a 3-month period. It gives us the average of what your blood sugar has been. And that number, if that number is over 6.5%, that then is a diagnosis as well. In some settings, for example, if you're pregnant, we might do what's called a glucose tolerance test, where you drink a sweet liquid to challenge your body to see where that number is. And in that case, if the number is over 200, that again becomes a diagnosis of diabetes. We always also talk about pre-diabetes, where if that A1C is anywhere above 5.6%, that means that you're becoming at risk to develop diabetes, full-blown diabetes.
Wow. What are some of the complications of untreated diabetes?
Yeah, and this is something really important to talk about because these are really the consequences, right? If we don't take care of ourselves and get those numbers in good control, then the ultimate places that the body where damage can happen are your heart. So one can have either heart attack or stroke. It can affect your eyes and circulation. So vision loss can be quite common. And then the kidney. So that's one of the organs that are really important that, again, besides the heart, the kidneys are the second greatest to be affected. And you can have kidney disease or kidney damage where your kidneys are not working well. And ultimately, if, again, things are not well controlled, you can lead to dialysis. And as Mimi mentioned earlier, the skin, right? So gum disease, damage to your skin, you sometimes don't heal well, you might have open wounds, nerve damage, so folks can have numbness, tingling, or neuropathic pain, which is pain from nerve pain that you can have as well. So those are kind of consequences of untreated diabetes.
Thank you, Jerusalem, for going over the complications of untreated diabetes. Mimi and Jerusalem are going to present us with a couple of possible scenarios. For our first scenario, Mimi will play the healthcare provider and Jerusalem will play the patient.
Hi, Jerusalem. Good to see you. How are you today?
I'm doing okay. I just got my lab results and it says that I'm pre-diabetic. I'm so worried about this because really both my mom and my grandmother had diabetes. And I eat so well and exercise. I just don't understand. I'm surprised about this number. I don't know where it came from.
Well, I'm glad you came to see me. It's not easy to get results like this. Tell me a little bit about what you know happened with your mom and your grandmother.
Well, unfortunately, with my grandmother, back home, since she wasn't able to get care, she ultimately did lose a limb. And really that scares me. Ultimately, my mother also ended up having to go on insulin. So I really don't like needles and I can't bear the thought of having to inject myself. So I'm really worried about this situation.
Well, the good news is that you're pre-diabetic and you're not a diabetic yet. More good news is that you understand your family history and you know where this could lead to. So this is an opportunity right now for you to either delay or even prevent a future diagnosis of diabetes. So this is a good time to reevaluate, what it is you're eating, what it is you are doing for exercise, and also a good time to see, are there any parts of my lifestyle that I could change? So as I get older, I won't have some of the problems that my mother and my grandmother had. Well, tell me a little bit about your diet.
I'm pretty busy with work, so I get up early and unfortunately I don't have time for breakfast. I have some tea. I get to work and, at lunchtime, I quickly run out and grab something from the store close by. And then at night we really have injera and, I try to make that for my family when I get home.
Okay, well, sound like a busy mom and a busy person in America. And so I can relate to that. A few things I would like to recommend for you is to maybe just have a little bit of protein in the morning, however you can get that protein, whether it's some non-fat yogurt drink or maybe a hard-boiled egg, just something to get you going in the morning. And protein allows you to have more energy without having to take in a lot of carbs. As you know, carbohydrates break down the sugar in your body, and that can contribute to diabetes. And so just knowing, how much carbs you're getting in. And when you're eating on the run, sort of the same thing. If you're thinking of your plate and you have to divide your plate into four quarters, that you want 3/4 of your plate or half of your plate, I'm sorry, to really be filled with vegetables that are low in starch. So you want to avoid things like potatoes. But then you want to have some protein on there. So if you eat meat, then meat would be fish at least twice a week would be your protein part. But now during Tzom, you might want to think about, how do I replace my proteins? Are you fasting this Tzom?
I was trying.
Yeah, so things I could really recommend, especially in our Habesha diet, is chickpeas, shuro. We all love shuro since we were kids, babies. So lentils, masur, and just trying to add anything that you can get a little bit of protein in, like maybe some nuts, things like almonds that have less fats in them, and also beans are a good source of protein. And then you can have some carb. You don't have to deny yourself the things that you love, because there has to be joy in food, right? So you can have whatever carbs you want to eat. Just understand the moderation, which you want to think about also when you eat injera, because even though that is our miracle food and we love injera, it's still a carb. It might be a little bit higher in protein or iron than some of the other carbohydrate sources that we eat, but injera itself does have about 25 grams of carbohydrates for a fourth of a cup of flour. So, if you want a 20-gram injera, 20 grams of carb in injera, that has to be a really thin injera and maybe a smaller size of it. So if you either maybe cut your injera in half, if they're large sizes, or make it at home in a frying pan where you can control the size of the injera. And just know you don't have to deny yourself that. You just need to look out and see what that plate looks like, what your proportion of vegetables to carbs and proteins look like. And also, don't have carbs just by themselves. Always have your carbs with some protein. So when your body metabolizes that, the blood sugar doesn't rise as high, because again, the proteins will give us energy for longer without raising the blood sugar.
That makes sense.
You think you can maybe be able to do that?
I'm definitely going to try. I like that idea of making sure that I combine the carbohydrates with my proteins. I think that's a great idea. Thank you.
Yeah.
And then what would you suggest about how exercise?
Well, what are you doing now?
Fit that in. I walk with my kids. I take them to the park and the playground. That's about all I've been able to manage.
Well, that is great. Any movement is better than no movement. So the fact that you're actually going and doing something is good. Some recommendations I can make that are not so hard to remember or not so technical is, if you're strolling, then you're not really exercising. But if you're walking briskly, so your skin is glistening, but you're not pouring down sweat, you can still talk to your children, but you can't sing a song because you would be out of breath if you were singing. That's considered exercise. That means that your heart is beating a little faster than it would normally do it if you're just sitting around. So when you think of how much exercise do I need, the American Diabetes Association recommends 180 minutes of moderate to brisk exercise in a week. And then if you divide that up by 3 days. So basically, if you could do something like 45 minutes to an hour where you're walking, maybe when you walk to the park, you guys can take the extra long way, or you can walk up a hill, and you can do this, break it up in 3 days a week, or you can maybe just do half an hour every day, 20 minutes every day. But any movement is better than no movement. So that's something I highly recommend. Also, look into what other folks in your community are doing, your neighbors or your friends or church members, and see if you can get a group going where you spend a little time outside or in the house even, and just do something, dance, some stuff for 30 minutes with your friends. That is perfect exercise, and you'll be listening so you know that you're working out. Okay.
Thank you.
Yeah, do you have any questions for me, Jerusalem?
No, I think I have my work cut out ahead of me, and I'll do my best. When can I get my labs checked again?
Yep. So here's what I recommend is that if you really want to monitor how things are changing with your blood glucose, you want to do the A1C test about every 90 days, every three to 4 months. If you're not in any grave danger. I'd say in your case, we should see what you can do, build on doing it for 1 week, then 2 weeks, and then slowly will become a lifestyle for you. And then when you get to the 2.5-3 month mark, come back and see me, and we'll redraw your A1C. We'll also be looking at your cholesterol and your kidney function, because when we choose to eat better and we're looking at our nutrition labels, then our cholesterol will also go down, because in diabetes, we know that heart disease is really something we want to prevent. And then something that I will just bring up to you, even though I know you pretty well, is your alcohol intake. If you find that you're, now it's spring, people are meeting for drinks more, and we're out of COVID. If it's, more than just a couple drinks a week, you want to cut down on that. And if you smoke, that's another thing that you definitely want to stop or slow down on. Okay.
Thank you for that.
You're welcome. And coffee's okay if you have a cup of coffee a day. Anything in excess is too much.
I know. My problem is my 3 teaspoons of sugar that I take with my coffee. I'm working on that.
Right. Well, maybe cut back on the coffee. Thank you, Jerusalem. I know you'll do well.
Thank you, Mimi. I'll see you in a few months.
All right.
Questions or comments at this point, please type your questions in the comment section. I already see a couple of comments. It's a great scenario. Thank you both. For our second scenario, Mimi will play the patient and Jerusalem will play the medical provider.
Oh, Jerusalem, I'm so glad to see you. It's been so hard to find some place to go where people understand me. I tried to go to 3 other doctor's offices, and this is just not for me. They don't understand what I eat. They think that I'm just have a bad lifestyle, and I don't know if they can help me.
Well, Mimi, thank you so much for coming. I think the first step is coming and getting this started. I really want to make sure that when you come here, that you feel comfortable coming to me, and that we can talk about, all the things that you need to make your life, better, right? So you've taken the first step already, and I congratulate you on that. You're here. So let's talk a little bit about how we can get things going. Your last lab did come back, and I know that you did take a look at it. Your A1C was at 13%. And how did you feel about that? Tell me a little bit about that.
I don't know what I'm doing wrong. I'm trying to eat healthy. I'm not eating any meat. I don't know. I don't want to buy food from outside. So I eat injera and my vegetables. I don't know how to change it.
Yeah, so we can work on both things. You know, we're going to focus on the things that you just talked about that include how you're cooking and what you're eating, and your exercise. We'll take a deep look at that. But for now, I really want to focus on how we're going to try to bring this number down. And I'm not sure if you remember our discussion before, but when the number is at 13%, you know, already this tells us that there might be some things going on in terms of your kidney, your vision, and some of the damage that happens when your numbers are this high. And we've discussed that before. Are you okay listening? I mean, are you okay and open to maybe talking about some medication and things that we can do with medicine?
You know, the American doctors always want to give me medicine. I think my medicine needs to be my food. I really wanted. I tried it.
Mhm.
I don't know if there's something different.
Yeah, tell me what you tried.
I tried metformin.
Mhm. And what happened? How long did you take it for, and what were some of the side effects that you
As
had?
soon as I started taking it, my stomach was hurting. I keep having to go to the bathroom. I was feeling nauseous. It was not for me. That's not medicine for me.
I understand. You know, that the thing with metformin, and I'm not sure if the doctors previously described it to you, that metformin is a medication. It's really one of the first line medications to bring the numbers down quickly. Of course, insulin is one of them as well, but metformin in particular, when your A1C is at 13%, it can really bring it down by about even 2 percentage points on average. So the thing with metformin is that it does, and it can for a lot of people, cause those stomach problems that you were talking about, that nausea, maybe a little bit of uneasiness, and even some bowel changes that can be disturbing. Yeah, or you might have a little bit of cramping. For most people, that goes away within the first week or so of taking the medication. Another alternative is to take metformin, the extended release version, which isn't just for 12 hours, but it works slowly over a 24-hour period. And that one tends to do a lot better for people and they don't have the stomach discomfort. But honestly, I'm not going to, this is, you know, we have a good relationship. I'm not going to try to tell you what you need to do, but I'll give you a little bit of information, right? So with 13%, the idea is that we want to get that number around 8% or below to avoid those complications that we discussed. So in order to do that, I'm happy to have you try lifestyle modifications, but I am worried that you already have some kidney function abnormalities that I'm already seeing. So that might not be a great option for you. I think lifestyle is definitely needed, but you actually may need to start some medication. How do you feel about that?
Well, now that you say other people get sick with it too, what if I tried to take some medication? How can I do that without feeling worse from the medicine than I do from the diabetes?
Absolutely. And that's a fair question because that's the balance that we're working on, right? We're trying to make sure that anything we give you doesn't cause further risk than the benefit that you're getting from it. Every time we talk to a patient, we try to balance out and let them would start off taking, and I would, in your case, because you did have a few of those stomach discomforts, I would recommend the extended release. You would take it once a day in the morning, and then we'd see how you do. And then you would come back in about 6 weeks to up to 2 months to come to recheck your levels to see where things are going. And we would also check again your kidney function levels and all the other things that are needed.
Okay. So many people in my family use insulin. I'm afraid of that. Do you think that's going to happen to me?
I think that if we follow the path where we monitor, we start you on the metformin, and that you're also working hard on your lifestyle and diet, I think we can get things down to a reasonable level where we can avoid insulin.
Okay. Anti-salalish. I'll try it.
Great. A few other things that I do want to add is that we also, we do need to get cholesterol levels and make sure that your blood pressure is also in good control. As you know, those three things work together, right? Your heart is a part of this, taking care of your heart health is a part of this whole equation. Two other things. One, we need to get you in to see the eye doctor, right? We need to get a baseline check to make sure that your vision is okay. They're going to do a good retinal exam to make sure that already that you don't have any damage from the high levels to your vision.
Yeah, it's getting harder to read.
I understand. And that's why we need to get you into the ophthalmologist as soon as possible, in addition to an optometrist. But the other piece is also gum care, right? We talked about the consequences of gum, what happens to our gums when we have high diabetes, high blood sugar. So getting into a dentist becomes very, very essential. And gum disease is one of those things also, again, that can affect our heart health as well as our circulation. And in general, I think we always forget about our gum health. And that's kind of the back burner for all of us. But it's a really important part of our full body health. And it becomes especially imperative in diabetes.
Can you refer me to an Habesha dentist, please?
Absolutely. We have a network of them, and I'm happy to help you find one.
Thank you.
So I'll see you back in a couple of months, and we'll get going on our treatment.
Feel so much better just coming. Thank you.
Number one, focus on lifestyle, diet, and exercise, which means intake of low carbs and fats, more intake of protein and veggies, in addition with exercise at least 3 times a week for 45 minutes or any daily movement. Limit alcohol intake and stop smoking. 2, don't wait until you have full-blown diabetes to do something about it. Get your A1C and cholesterol checked yearly. Number 3, medication can prevent poor outcomes of diabetes. Take the time to learn about the medication and its side effect. We are going to move to Q&A. If you have any questions, please put them in the chat box or raise your hand. Our Habesha Health team will unmute you to speak up. We do have a couple questions that already came up, so I'll start asking those questions. First question from our audience is, why can't one take more coffee as long as it is without sugar?
It's not so much that you can't take more coffee. It depends on your cardiovascular health. Caffeine does tend to speed up the heart rate. And also, I think sometimes if you are feeling really speedy with the coffee, you might skip meals, and you don't really want to skip meals. You want to have, small portions frequently throughout the day. Coffee is one of those things where it's wonderful. And we don't necessarily need to deny ourselves of it, but all things in moderation. More than a couple cups of coffee a day is probably too much. So I'd stick to probably less than 2 or 3 cups of coffee a day.
And I might add, if you have high blood pressure, you definitely want to stick to the lower end of the number of cups of coffee, because it does increase your blood pressure. Like Mimi said, it is a stimulant, so it can definitely do that.
Next question is, should one check blood pressure levels at home with a glucose monitor? And how often should it be checked?
So I'll take that one. You should check both your blood pressure and your blood sugar at home. I think, knowing yourself, knowing your body is great, even if you don't have to do it frequently. So for pre-diabetes, I think if somebody is checking their blood sugar even once a week, fasting in the morning of what your blood sugars are like in the morning. So as Jerusalem mentioned, anything less than 126 is great. Anything higher than 126 gives you a goal. What am I eating at dinner generally? How can I bring that number down in the mornings? For someone who has uncontrolled diabetes, you want to be checking your blood sugar before meals. And so this could be, someone who's A1C is in the 13s, or anyone who takes insulin. You want to check your blood sugar before each meal, before you administer your insulin, so that you don't bottom out your blood sugar. And then also at night before you go to bed. It gives you an idea of the range. And then as far as blood pressure, I think if you have a cuff at home, knowing your blood pressure is a good thing. Checking your blood pressure in your own environment, your own setting where you're comfortable is ideal, because when you go to the doctor's office, most people's blood pressure is higher than what it usually is anyway, because they're nervous, the setting is different, maybe they were in a hurry trying to get there. So I do recommend, just knowing yourself, knowing your own numbers.
Thank you for answering that. Next question is about being pre-diabetic and wanting to get pregnant. Last A1C was 5.9.
So that's a great question. I think especially when you're in the preconception phase, it's really important to have that blood sugar be in a good place, right? Because if we start off with high blood sugar prior to becoming pregnant, that puts us at risk for having for gestational age baby. So diabetes can increase the size of the baby. And then when the size of the baby is increased, then delivery becomes difficult and there can be some complications. So if you're in the preconception stage, this is a really good time to start working on that pre-diabetes and bringing it down. That's something that I would highly recommend. So doing the lifestyle and exercise stuff that Mimi was talking about earlier, if you can bring it down, that would be fantastic.
And if I could just add to that, also, if your blood sugars tend to run a little higher, it could affect conception itself. And so maybe asking your healthcare provider for a glucose tolerance test to see if you're having any insulin resistance, because if that's the case, then it would be a little harder to get pregnant. And so being able to have a better idea of how you manage your blood sugar. And I have, when I have worked in women's health, I have prescribed metformin to pre-diabetic women just to get their blood sugars down enough and use enough insulin that they're able to conceive. And some of them go on to stay on it during pregnancy because they end up being gestational diabetics. And some of them will get off of it once the pregnancy is established. So it's very huge correlation, I think, with conception and preconception and blood sugar levels.
That's a great question. And, because of the gestation, gestational diabetes is also one of the things, if you've had a history of gestational diabetes, then that puts you at higher risk for developing diabetes itself later on. So we really want to try to avoid that if we can.
Thank you both. Next question is, what do we know about the correlation between stress and raised A1C / blood sugar values?
So I think stress is really something that changes your hormonal makeup. And so when you start having higher cortisol levels, for example, then your blood sugars go up. It's really, diabetes is one of those diseases that really is an indicator in your general wellness, right? Your mental health, your physical health. It's really where a lot of things sort of meet. And so when you're stressed, it is so hard to keep your blood sugar down. When your body's stressed, maybe from an infection or from, a death in the family or something going on that is stressful at work, your blood sugars do go up. And so really managing your stress is a huge part of lifestyle. And I didn't even talk about that in the discussion earlier, but, stress can be just as bad as smoking, drinking alcohol. It can do the same sort of damage. So yes, managing your mental health and your stress levels is a really big part of managing your blood sugar.
Yeah, and I can just, attest to that as well. When Mimi was talking about cortisol, right? That is the kind of the fight or flight reaction that we have, right? Our system is working in that way. So everything is constricted. It's kind of the same way, like your blood pressure goes up, your heart rate goes up, you start to have sweaty palms. That is what happens during a panic attack. That's what happens during stress. Some people have chronic stress, right? If their cortisol levels are high for over long periods of time, our Habesha community, we've dealt with so much, for some immigration, all of this stuff coming here, what's going on back home, all of these concerns, our our cortisol levels are chronically high. That correlates to high blood pressure as well as the A1Cs going up. I had a patient that I remember when I was working at San Antonio who would come to me and she would say, you know, Jerusalem, every time I check my blood sugar after I deal with my teenage daughter, my blood sugar is through the roof. What's going on? And she correlated it herself. She said, this is it. When I'm stressed, my blood sugar and my A1C is high. When I'm not stressed, I'm good. So please help me with the stress. And it was really, it's a good revelation, and it was important for her to see that herself, because she was checking her blood sugars regularly. And when she would have the conflicts with her daughter, that would happen. So I'm glad that was a great question. Thank you for that.
Yeah, and the audience, if you want to ask a question, please raise your hand and we'll unmute you so you could ask questions to yourself directly.
Earlier, you stated that diabetes is nearly exploding in the Habesha community. My community pharmacy experience in Eritrea for about 46 years also attests to that. And from my experience, I believed one of the reasons would be the nutrition and lifestyle change, shock the body gets from the countryside to the city life, and etc. What other reasons or hypotheses can you tell me about this, if there are? I mean, why diabetes is exploding in our community, even in our country back home?
Yeah, well, at least what I have seen, thank you, that's a fantastic question, and now let me answer it too. At least what I've seen when I've gone back home, I have seen significant dietary changes. And I think a lot of it has to do with just people not having access, for example, to teff. You know, something as simple as that. People are having to eat mix because they cannot afford teff. I see many more people resorting to bread or going to the bakery to have bread with the shura or whatever, because it's just what has happened in our access to what we're eating back home. I think that's one of it. But also what we just have discussed is the stress, right? Those cortisol levels, the life, what's going on in our communities. I think that's one of the things. And then when you come to the city, you know, people are living in these taller buildings without areas where they're exercising or playing outside, you know, urban life versus the countryside. I think that's one of the biggest things that I see back home as well. Yeah. I don't know, Mimi, go ahead. If you have something to add.
Yeah, I mean, and the same thing about city life or even immigrating to, you know, the West is that the work that you do to make the food that we make, you know, is the labor itself is part of exercise. It's part of moving. And now we just, actually in the United States, we're at the point where we just click a button and order our groceries online. We don't even bother to get in the car and drive to the grocery store, walk in and push the cart. So there's less labor in preparing the food. There's less access to some of the foods that we're traditionally used to. And, you know, we have seen what has happened with the Native Americans here when their diets was completely changed. They have the highest concentration of diabetes anywhere around the world. Specifically the Pima Indians in Arizona. And that has everything to do with how people were able to harvest their own food, how they're able to hunt and gather their own food, how they prepare their own foods, and what they're used to eating. So just globalization, you know, just really trying to get back to the basics, I think will do a lot in preventing this large community shift towards diabetes.
If I may add, from my observation, you know, in our cultural diet, supposedly, because we were eating mostly grains and vegetables and stuff, not much meat because of the scarcity and the hardship of life. Now, when people come into towns and cities and they become successful, they think it's one of the ways of improving their family's lifestyle is to put meat, eggs, and butter on the table every day. In fact, I was telling this to many of my patients because you think you are improving your family's life, but you are actually making it even poor health-wise and diet-wise. That's one of the misconceptions that we have, because when you connect diet with wealth or success, that's one of the problems I have noticed, and I have been trying to explain to people that. So we have that in our community. Thank you.
Thank you.
Thank you. Next question that came up is a question from Mimi in Jerusalem. Are you aware of any Habesha nutritionists? Is there a network of such nutritionists that do virtual visits?
In my network, I don't know. No, I don't think I know anybody specific, but I definitely, always trying to expand my network and look for folks that can help. Culturally, I think being bicultural is a huge thing. So if I ever come across such a provider, I will definitely let the Habesha Health Network know, and they can post it on the website.
It sounds like we have Dr. Betiel Aklilu, who does nutrition. She's in the chat box. I just caught it. So
there we go.
Nice to make a connection. The next question, Jerusalem, if you could answer, what are the warning signs that sugar level is too low? What should a person do if their blood sugar level is too low?
Yeah, thank you for that. So this becomes important when you are taking medications to lower your blood sugar, or when you're taking insulin, or even in general, but mostly in those scenarios. And what you would have is your blood, especially if you're not checking it regularly, you may have dizziness, feeling of lightheadedness, feeling like you're going to faint. And in worst case scenarios, if it gets too low, people can have seizures. Right. So that's what we try to avoid and make sure people are aware of when we start people on medications to lower their blood sugar. So those are the main ones. And they should always be prepared with either having some juice with them or a packet of glucose or sugar that they can quickly take to bring those numbers up.
Thank you. And Mimi, I know you touched on this briefly on the side effects of medication and insulin. Can you elaborate a little bit more on that?
Yeah, I think in my practice over the years, metformin being the first line medication has always been the challenge, trying to get people to stay on it. And so I've taken the approach of, using the extended release metformin that Jerusalem mentioned, starting at a very low dose. And increasing it very slowly. By the time a person comes to me and their A1C is in an uncontrolled range greater than 8, it took time to get there. So I don't have to bring it down right away. It is easier to get a patient to buy in to the plan of care by having less bumps in the road than it is to go really fast over the bumps, because that, especially with my Habesha patients, not to generalize, but not just Habesha people, but people who have the same sort of cultures as ours, a lot of Yemeni patients, it's really hard to buy into the pharmaceutical answer, and then to have that pharmaceutical answer not make you feel well. You have about one chance. They'll take the first pill and they won't take any more, and you've written this 90-day prescription. And so just really trying to hear folks about their concerns and about their experience, and doing it in a way where people can be as comfortable as possible with medication before you start, trying to increase dosages or making that the only answer, because you have to sort of shift through people's beliefs. You have to shift through their day-to-day comfort. Can they go to work and be comfortable enough they don't have to keep running to the bathroom, or they can't get through their day? doing things where the diabetes didn't change that for them. They could go to work and get through their 8-hour shift. Now they're taking this medicine that's supposed to help with something they weren't feeling, and now they're feeling something. So when it comes to any medication, just metformin being one of those, that's the worst. But whether it's an antibiotic or anything, is really trying to understand, like, what's the threshold that this patient has to want to take a medication. I have to be able to convince them that this is better for you than the disease that you're experiencing. Is that helpful?
Very helpful. Thank you. And my next question is for Jerusalem. Will a person diagnosed with diabetes always need medication? How will a clinician evaluate whether this medication is the best treatment for a patient?
That's a great question. And again, that's what people, that's the biggest fear, and that's the biggest concern for no matter what disease, right? Whether it's high blood pressure, whether it's cholesterol, once I start this medication, is this going to be for life? And it's a tough one to answer, but I think that's why we have the conversations and we have regular checks to see. I have patients that I've started on blood pressure medications that once they've made lifestyle changes, they've been able to come off. So people are able to taper down or come off, or like Mimi was saying, start at a low dose. If they have to go up, they go up. And then with lifestyle changes, if things improve, you can definitely come down or off, depending on the situation and depending where your level was to start. So it's not a forever situation. And even with folks that are very high and have very, over 13 is quite high, honestly, that we were talking about, just kind of, as an example, that is a very high number. And those folks mostly already have consequences of kidney damage, et cetera. So those folks might have to be, for example, on insulin for a short time at the beginning to bring things down. And then we can take them off of insulin as the things like metformin start to work. So it's kind of shifting. So yes, I can say that people can come off of some things, but it depends on how far along their diseases and the consequences of their disease are. Basically would be by making sure that we recheck those numbers, right? So the A1C is one number that we check. So they would come back in 2 to 3 months to recheck that number to see if that's coming down. We also evaluate their kidney function regularly, because that's not only because it's a consequence of the disease, but it also, with some medications, you can have side effects to your kidney as well, right? As we know, when we take medications, they either filter out through the liver or the kidney. So whenever we take any medications, we're making sure that we check those levels and our electrolyte levels. So we check those regularly, once every 3 to 6 months, and we see where things are going. In addition to the other things, like I said, going to the ophthalmologist. If they go to the ophthalmologist and they're like, hey, already we're seeing retinal changes and diabetic disease in your eye, those are some ways that we can monitor folks and adjust medications as needed, either increase or decrease, and figure some of that stuff out.
Thank you, Jerusalem. And how often should a person diagnosed with diabetes see a doctor to optimize diabetes management?
Well, I would say at initial diagnoses, we should at least check the A1C between 2 to 3 months until we get a feel for what's going on. I frequently will see a new diagnosed person several times within that time. So I might bring them back in 2 weeks, because this is another thing where you get somebody acclimated to the diagnosis. They hear it the first time and then it feels like, oh my gosh, I'm going to die. But then the second time they come back and like, okay, I tried some of this, lifestyle stuff, or I did this medication, and I keep seeing them frequently initially. Also, if a person's starting insulin, I definitely see them, very frequently the first 2 months. And then if it's someone who's established with the diagnosis, somebody who's got controlled diabetes, you can even go as spaced out as every 6 months. Somebody who's able to manage their A1C, they know their meds, they eat well, they exercise, twice a year. It can be something that they maintain well.
Thank you. And last question I have is, how do other factors such as high cholesterol and high blood pressure affect a person that has diabetes?
I think we already touched upon that, but it's just, it's about cardiovascular health, right? So one of the big consequences of diabetes is, poor outcomes of cardiovascular health. And those things factor into it. So when we have a person that's first diagnosed with diabetes, the automatic first part of the panel is to check their lipid panel. And then also to make sure that we know what their blood pressure is, right? So all of those things factor in. So for example, if somebody had high cholesterol, didn't have diabetes yet, or their blood, we would do a calculator to see what their risk was of developing cardiovascular disease. And those outcomes would be either having a heart attack or a stroke. So all of those things we put in together. People, for example, that have high cholesterol and then develop diabetes almost automatically have to go on a statin to protect them from having those consequences. But because it's all interrelated and affects your heart health, is why those numbers are also very important. I did see one quick question that I just wanted to quickly touch on that Betel did have about how do you help somebody change? I think optimize change. And I just wanted to address that very quickly is motivational interviewing has been one of my tools that I've used. It's really about, like Mimi and I were saying, creating a space where that person develops trust with you. These things don't happen overnight, right? You might have to have 3, 4, 10 visits before that person trusts you or feels comfortable in the space that they're in that you've created. You have to create a safe space. So that's the first thing. And then also making sure that when they tell you, like really prioritizing their concerns, not your agenda. It's not your agenda. It can never be your agenda. It has to be their agenda. If it's not their agenda, nothing is going to go the right way. So really trying to figure out what is important to them and giving them guidelines to help manage that change. But look into motivational interviewing. I feel like that has really helped me and recenter how I address all kinds of issues, whether it's stopping smoking, helping folks with deciding, all the things that I talk about.
Yeah, I definitely agree with that. It's all relationship building when it comes to primary care, particularly. And the other thing that's maybe a buzzword also is trauma-informed care. And even though that's a buzzword, what it really comes down to when I think of, the Habesha community is that there's a lot of things that are fear-based, and it's like removing some of those fears. The first discussion we had about the pre-diabetes is, yes, this could all be really bad, but if we take the fear out of it, this is actually really good news because we have time now to do things to prevent some of these bad outcomes. So, and just meeting people where they're at, it's really difficult when you get a patient who is just like, oh, I don't take meds. I don't believe in meds. I can't change a person's beliefs, but I can slowly maybe get them to see my point of view, and they may then try it or they may not. And if they don't, then what? I can't just drop them as a patient. I then have to work with what I have. And if the person says no meds, no meds, no meds, okay, no meds. Now we're going to go to harm reduction and we're going to work on lifestyle stuff and we're going to work on the things you do believe in. And so that I think is as good as it can get, right?
Yeah, motivation interviewing is vital, and it's used by counselors as well and case managers. I'm glad that you touched on that, Jerusalem. And Dr. Aquilo, if you could put in the chat box how people could reach you. And I also see that the Bay Area dentist, Dr. Hibred and Dr. Lula, there is one more, Dr. Muse Suhatu. Sure you could Google them and find their practice office. But it is great that we are connecting the dots and creating a network of Habesha providers. Thank you all for joining today's session on managing diabetes. Thank you, Jerusalem and Mimi. The audience, please join me in expressing appreciation to Mimi and Jerusalem. And also thank you to Habesha Health for making this event possible. I enjoy moderating this discussion, and I hope you will join us for our next community discussions. Recording of this discussion will be posted soon at habeshahealth.org and on the YouTube page. And there will also be a feedback form that will be sent via email, and I'm sure will be posted on this chat box as well. And this concludes our event. Thank you all.